Right, hello everyone. So this session really is about how COVID is changing policy making and thinking um, across Europe. Um, and we've got some great panelists. I'd like to welcome in person Professor Walter Ricciardi, who's a chief science advisor at Malgeri ICS, which is a large hospital and rehabilitation group in Italy, a private sector operator. And he's also the scientific advisor to the Minister of Health in Italy and also to the Prime Minister. That's right, isn't it? And on screen, we have Martin Brunninger, who's Director General of Health and Social Care in Austria. So he's the man who's really responsible for steering policy in Austria for health and social care, so the integration of the two. And finally, but by no means least, we have Marcus Siebert, who's the Senior Director of Reimbursement and Health and a healthcare economist at Abbott. So we have someone here who's looking at more from the medtech angle, I guess. So I think we're going to look first of all at the impact of COVID on policy making, and then we're going to be looking in more detail at what that means in terms of real innovation, and also how this means nation states are changing their approach and strategies towards medtech. So let's start then by looking at the impact COVID has had on policy-making thinking. Martin, let me come to you first. How has the COVID crisis affected? You've had a ringside seat in this, of course, on policy making in Austria.
Yeah. Thanks for having me again, Max, and hi to everybody. So how did that change policy making? I think it changed policy making dramatically. Why? Because for all major policies that you do in any government, you need a legal foundation, and the legal foundation is a parliamentary process. And the parliamentary process usually takes at least 9 months to 12 months until you really have issued a bill that's actionable. With COVID, that obviously was every week we had a parliamentary session that changed the legislation that we needed to tackle the pandemic. So the speed of policy making accelerated tremendously. What did we specifically do to tackle the pandemic? There's a lot of points and issues that is similar to all sort of governments. How do you basically procure the vaccine? How you distribute it? Who is giving the vaccination, etc. So all those sort of things. But the more the hot issues really, how do you use the data that the government has to organize vaccinations? That was the key thing that we have organized. I told you yesterday that we have in Austria a vaccination record, which is mandatory for every citizen in Austria. There's no opt-out option. There was another legislative change that we did. We have an opt-out option for the electronic health record. So there's about 97% coverage, and only 3% choose to opt out of having an electronic health record. The legislative change that we did, we didn't give them an option to opt out for the vaccination record. So every Austrian who receives a vaccine in any form, has to be recorded on this electronic record. With this, we have created a dashboard. I'm not sure if you want to show that. That was tremendously helpful for us. Because we knew from day one where the vaccine was distributed, who received the vaccine, and we could analyze that. So we could drill down per age group and also per risk group. And the risk group we defined per morbidities and comorbidities they had, and how critical they are with the progress of COVID-19. So we had a prioritization of not only the elderly, as we have it in every country. We could drill down also on what type of morbidities younger people had. And they were also obviously prioritized. And you can see that what type of
Martin, can we have the
medication.
slides? Sorry, Martin. Can we have the slides back, please? Can we go on to the second slide? Martin, you need to say when you want to go on to the next slide. Can you see the
Sure.
slides, Martin? Okay.
Yeah, we can see the slide, so that's fine. You can stay on that slide for some time. So it just shows you the political regions and sub-regions and smaller communities that we have, and you can drill down even more. So every kind of small mayor could say in his community you have 90% vaccination of all 80 plus year old citizen, or you could say you have 50% vaccination for everybody who receives oncology drugs, for example. So you could really prioritize according to the need to the vaccine. That was very critical at the beginning when we had a shortage of supply at the beginning of the year. I think that was true for all jurisdictions in Europe. And then there was a boost of supply, and then it was just only about how could you how could you make it as easy as possible to get a vaccine. Austria was kind of in the middle field. But now, where this dashboard becomes more critical, is to reach those people who do not go for the easy accessible vaccination opportunities. So now we can use the dashboard again to encourage those who are difficult to reach. And that's something. And why do I go into that detail? Because it is a great tool how we could use the vaccination record to really understand who is vaccinated and who is not. And that was a critical bill that was issued in the parliament, that those people are obviously to us not visible who that is. We just have an anonymous number behind it. But those people who really need the vaccine and are really ill and they still haven't got a vaccine, they can be personalized now. So we can basically uncover who that person is behind that number. And that obviously needs a legal foundation that was issued in the parliament. So that type of policy making accelerated to a light speed, and that was quite helpful.
And now
So
you
you can
now
you
you
can
can
flip
use
through the
this.
last three slides. It just shows you the granularity that we can achieve with a big data approach, with a digitalized platform, which was quite helpful in fighting the pandemic, and use all the instruments that we have at hand.
Okay. Thank you very much, Martin. And Walter, how about you? How did the crisis affect and change policy making in Italy?
I mean, certainly the speed of decision making as in other countries, but the most important change was reversing a trend that affected financing of healthcare in Italy in the past 20 years. So like this, in a moment, healthcare became one of the priority of the government, being Italy the first country struck outside China. So the governments, but all the citizens realized that investing in healthcare was a priority, and it happened. It happened because, just to give you an idea, intensive care units beds were doubled in less than 5 months. We recruited 35,000 more doctors and nurses. And moreover, we, in the Next Generation EU plan, started to invest in health as a priority.
Yes. So how much more money has gone in? I mean, how much?
Yeah, but just to give you an idea, in the past we had only budget cuts. The Minister of Health in 2020 increased the budget 5 billion euro, and now it's increased at 10 billion euro. So 10 billion euro, which was something that never happened in the past.
Gosh.
Of course, there were a lack of doctors.
So that's an increase of what, 5 or 10%?
10%.
10%. So
Yeah.
it's 100 billion. So
Yeah.
increased it by
Yeah.
10 billion to
Approximately 10%.
Yes. Yeah.
This is a substantial investment. And moreover, it's not only a matter of money, it's the attitude to the health sector that changed. So people realized that investing in health shouldn't be considered only a cost, but investment in the future of the country.
Yes. And that's meant that you're now rolling out a much stronger primary care sector.
Exactly, because essentially what happened is that not only in regions, you know that the National Health Service in Italy is regional based, but some regions, for instance, the largest and maybe the most important, Lombardy, invested a lot of money only in the hospital system. Right. They have a world-class hospital system, But they were in trouble when the pandemic came because hospitals became, rather than a source of protection, a source of infection. And that was because of the lacking of a strong primary healthcare pillar and the lack of public health facilities. That's the case now to invest in that.
Yes, yes. So a real sea change in attitude.
Absolutely, absolutely. Total change, a dramatic change. Italy is a reactive country, and when the reaction is strong, you can catch up even some cuts or some attitudes that were characterizing the country in the past 20 years.
And obviously, at the moment, you've got a coalition, haven't you, led by a technocrat, haven't you, in the form of what's his name,
Mario Draghi,
Yeah, Mario Draghi,
the
former head
former
of-
president of the European Central Bank. I mean,
So,
yes.
so Italian governments come and go
Yeah.
at quite a rate normally.
Yeah.
So do you think there is a political consensus over this investment in healthcare? I mean, or
Indeed.
are we going to see a new government come in and just change everything?
This is a trend which cannot be changed. I don't think there is any single political forces. You know, you said there is a coalition government, left, center, and right, a kind of big coalition headed by certainly a technocrat, which is a very sophisticated politicians. But essentially what's happening in the future that no single person in Italy would deny the importance of investing in the health sector.
Right. Okay. So it's a real sea change.
Absolutely.
In Italy. And in general, I guess, Marcus, Sir Abbott, we're seeing a trend towards value-based healthcare. Has that been accelerated? Is that going to be accelerated by COVID, do you think? I mean, what are you seeing there in terms of value-based healthcare?
Yeah, thank you very much, Max, and thanks for inviting me to the session. So I think very thoughtful insights from the colleagues already. And before I come to that, I just want to make one additional comment on what we have seen. I think it illustrates what Walter just said. I mean, I'm basically looking at the medical device part of Abbott, and which is predominantly, are we active in the cardiovascular and also in the chronic pain and movement disorder space. And lots of our products are obviously, for treating chronic conditions in cardiac and as I said, also in neurological care. And so one thing which we have seen accelerated clearly, through the crisis is the use of e-health and remote solutions. And an example, for instance, can be that the transmission of data from a cardiac implant, like a pacemaker or a defibrillator, can obviously be done remotely, but you can also move to remote consultations, and instead of face-to-face consultations. And these solutions have been there in the past. And the sector has also been trying and fighting to to kind of establish them as a valid alternative also to whatever more traditional face-to-face in-office solution you would have. And what we have seen, of course, is that forced by the crisis, these remote solutions have now become much more prominent, have also received better funding, and I'm responsible for health economics and reimbursement. So it's really also the funding side of things that I look at, and certainly Italy was a very good example that all of a sudden we have seen that a more active approach to funding remote solutions became possible. So there was clearly an acceleration. There was clearly a recognition of medtech and remote solutions as indeed solutions, to the acute problem. And then in general, I would echo what the professor just said. I think, of course, all of that comes, and the whole crisis comes at a cost. And we have seen, obviously, the acute cost of treating patients. But now, obviously, there is a lot of awareness also about, what happens to the care that has been pushed out. We are seeing patients, coming in later and so forth. What will that do to their trajectory and to the overall costs in healthcare? But also, there has been more, obviously, recognition and simply more awareness of healthcare. It has been on everybody's mind day in, day out. So I think if we take all of that together, I would echo what the professor just said. I think there is more awareness also of healthcare and what it does to society. I think we are looking into more conscious investment in healthcare, and this to come to your question, Max, is what brings us to this whole notion of value-based healthcare. I think it's we need to make choices, right? What we can do in healthcare is probably endless. The demand is endless as well. But what we also see is that we are, I think, in many instances on this, flatter part of the curve of diminishing returns. In other words, the more we do, we might have to pay a relatively higher price for what we can still, squeeze out of healthcare, so to speak. Meaning, the possibilities are there, but we still need to make tough choices about where to invest. And I think a framework like value-based healthcare, like understanding what means value to whom, and also recognizing that value can be very layered and can appear to different players in healthcare in almost different shapes and forms, I think is a one very important step to build a foundation under decision making in healthcare. So I think the crisis has also accelerated that, or at least sharpened the recognition of the need to constantly also have our tools ready to make wise decisions in healthcare.
So you're talking about so when you're talking about value in healthcare, you can be talking obviously about the Michael Porter kind of model of payment by results, and also you're talking about the ability to consider value more deeply, perhaps in terms of healthcare and thinking about where value really lies. Do you see this changing in Italy? Are you moving towards the Michael Porter model of payment by results, for example?
No, I think we are following the European Commission model. You know that I was part of that panel. The expert panel on investing in care, in healthcare, say that, of course, beyond the Michael Porter approach, which is a kind of technical and economical value, you should add the personal value to the patient and the societal value to the society as a whole. So in Europe, I think, given the fact that we have a welfare societies where we take care of citizens essentially from the cradle to the grave, we should be caring not only of the single aspects of the technical and economic value, but we should take care of the allocative value. So government have to manage in a way that giving money to some form of actions or to some patients doesn't harm the equity that should be granted in our society, which is more difficult because essentially it's not provider-based or specific product-based, but it gives the possibility to integrate all the different point of view. And this means that in the future years, we have to work together, essentially starting from patients, then doctors or in general professionals, managers, politicians, and industry. So we have to build a kind of community of practice to share not only the general concept, but also the practicalities. It's a long way around, but I think it's it's the only possibility to grant sustainability to our system.
So are you moving towards patient-recorded, rewarding healthcare providers by patient-recorded outcomes and outcomes, or is that still some way off in Italy?
It's still very embryonic because, of course, in every, again, single opinion of the expert panel in the past 8 years, we raised the issue of having a European health space data, which means sharing the data of every single citizens rather than patients in the whole of Europe. I'm also chairing the Mission Board for Cancer. We give for granted that in the future, care for cancer will be based on a digital pathway. The fact is that there are still a lot of barriers to this. Yes. Some are privacy, some are, the fragmentation of information, but the Commission is going very quick, as I said, and there is already a technical standard for these. There are, COVID pass is just an example. In principle, every single of the 430 million European citizens is able to have his or her vaccination status in a common database. So it's just the pathway to this that is going. We have to speed up the process.
So it's interesting, actually, because I know I was talking to the European University Hospital Alliance, which brings together, I think it's 12 big university hospitals in Europe, including San Raffaele in Italy. Yeah. And they were talking about moving towards so that the healthcare data they were collecting could be understood by all the other members of the university in the association, and that you could start to have a pan-European description of illnesses, which was similar, for example. So they were saying you want to have a situation where if you look at the healthcare data in Sweden, it's in English, and if you're Italian, you can understand it, and it's using the same language and the same terms as you'd use in Italy. So so that's the kind of move you're talking about.
Exactly, and what the Commission is doing, the European Commission is really working hard in that direction. Of course, member states, which is the responsibility of member states, healthcare at the moment, have to comply. But for the first time ever now, there is even a formal body bridging the gap between the European Commission and member states to discuss about that. And it's not only the Ministry of Health, it's also the Ministry of University and Research that are working on that. Of course, it's difficult. It's something that starts from a very big fragmentation, but the direction is clear. I mean, we are building a digital pathway in Europe. That's the case. That's the future. The problem is when we are going to achieve this.
Yes. Okay.
It's not if.
It's not when. Yes. And Martin, how about you? Are you moving towards value health in? You're not really there, are you, in Austria? You've got this great electronic patient record system, but when it comes to DRGs, you're not moving really towards the Michael Porter or value health model, are you, much at the moment, or am I wrong? Martin, we can't hear you.
Sorry.
That's okay. We can hear you.
Can you hear me now? Yeah. Okay. Sorry. Unfortunately, I have to say you're right in your analysis. Like in any field, improving performance and accountability depends on having a shared goal that unites the interests and the activities of all stakeholders. In healthcare, we all know stakeholders have a myriad, often very conflicting goals, including access to services is one goal, profitability is another important goal for some. High quality, cost containment, safety, convenience, patient-centeredness, and satisfaction. I mean, these are all often very conflicting goals. And if you're a federalistically organized nation as we are, you have it even more complex, and there's even more fragmented set of goals. So it's all easy to say, and then think on a piece of paper. It's easy to draw a nice system. But uniting different goals of all our stakeholders is very, very difficult. It's a bit of a dilemma. Yes, you're right. We have, I think, and comparing us to other countries, we have great instruments and we have great ways to measure things. But using them to create better value in healthcare is still a very political question that's difficult to solve at the moment. So one of the key things is to define value and to define mutual goals that unites most stakeholders in our system. And when you have achieved that, I think then it's easier to create real value. And a colleague said the stage in Italy is embryonic when it comes to patient-reported outcome measures. In Austria, I would even say we are the stage of a germ cell, so it's even way before the embryo. There is ideas there and we planted seeds, but it's still something that has not arrived yet in people's minds. And I said yesterday, one of the key things to achieve patient-reported outcomes, which I think is the overarching goal for a value-creating policy, is health literacy. And health literacy is, comparing to other OECD countries, Austria is relative to its other educational level not very good. And I think that we have to tackle, because that will fuel prevention, that will fuel that they can articulate what they actually want from the healthcare system, And once this is a stronger voice from the patients, I think that's when we can start drawing good policies in terms of value-based outcomes.
Yes, and I suppose there's always that question of where you spend the money, isn't there? I mean, I think you were saying that, in fact, if you look at the Austrian drug budget, I think you were saying a very large percentage was spent on a few people with rare diseases. I don't know. Can you? What was the statistic, or did you? There was a very interesting statistic.
Well, that's I think that's the same for all OECD member states, that we spend an increasing amount of our drug budget for rare diseases. And that obviously is an ethical dilemma, and I'm not really trained to talk about ethics, but that is definitely a problem that we have to tackle, because there is obviously a need for medications for this for these rare diseases. There are very potent drugs coming on stream, especially the gene therapies. There's more and less potent drugs coming on stream, but there's definitely a few very good ones. But the price often exceeds a million euros per year per patient, and that obviously is, in our view, difficult to sustain. But we're not alone in that. That's true for all countries, as I said, in the OECD.
Yes. Okay. So going on really to looking at so COVID is leading to much more innovation in healthcare, isn't it? Really. I mean, this was your point, Martin. I mean, are you seeing that in a big way in Austria, Martin? You're seeing the deployment.
Yeah.
I mean, you think innovation, these remote solutions will occur not just in B2C telehealth, but more generally, or?
Yeah, no, I think that's the good thing about everything. I think that wasn't all bright outlooks that I articulated, but one that is definitely good is obviously, as I said at the beginning, the speed of policy making. That's good, and the other thing, what you're just asking, is the speed of innovation. But one person yesterday said there's yet to be seen what e-health really brings to our society and what it really brings in value. There's a lot of innovation going on at the moment, and the plausibility of these approaches is all very high with most of these technologies that come on. But really putting the building blocks into a system, we still have to see where we can help. I think one thing that we are trying to fuel innovation, to put it into context of our system, is to build a platform for it, and that's the data platform that we are trying to build in Austria, based on our digital instruments that we have. So we have increasing amount of data thanks to our digital instruments, using this data for innovation and putting those new building blocks in place. That's what we hope will accelerate even the innovation that we see, and obviously put it in better in context as well.
Because you built the electronic healthcare record system in Austria. You've got a central, single telehealth solution, which is going to gather the data that you need to populate that database. So you're very much of the opinion that the state should essentially have this data, and you don't want it going to telehealth unicorns, or you don't mind working with them, but you're not against the private sector, but you think the data is very important, that you don't want to see the data siloed into many companies. That's basically your view, isn't it?
It sounds very communistic, the way how you put things into my mouth, but I think in a way, I think it's probably the right thing, and I guess it's also fueling innovation in a better way, because we have no value in creating more data islands and running for data from private companies, because there's only value if you have a homogeneous set of data of all patient groups, because if you otherwise you create biases, and there's not much need in that. I think I always compare it with the infrastructure. If the state provides for the infrastructure, it provides a much better foundation for innovation. And I want all the innovators to really create innovative and great solutions that we can improve the quality of care, and not capturing as much data as possible, as much data as possible. So I think you're right there. And telemedicine is a very good example. I'm not a big believer of telemedicine companies capturing data, because telemedicine is from an infrastructural point of view something extraordinarily simple. It's a telephone line that we have set up, and now we have set up a video consultation platform that we roll out to all our contractual doctors. That cost us 300,000 euros, so that's next to nothing compared to even our smaller healthcare budget that we have. It's not really a big technological heavy lifting, but providing that's basically giving innovators a platform to improve the way how we communicate between doctors and patients. It could be, for example, a melanoma recognition tool. It could be a language recognition tool. It could be, there's so many fantastic innovations that we can put on our platform, almost like an app store to as you have it with Apple. But that's where the innovation really makes sense, but not in competing for patients to have teleconsultation platforms. I think there's
How's
less
this
value in
playing
that.
out in? Thank you, Martin. So, how's this playing out in Italy, Professor? Are you seeing the similar?
Indeed. And just to give an example, telemedicine was not even reimbursed in Italy
Yes.
before the pandemic. Now it's reimbursed. What we call is a minimum level of care. Has to be granted in the whole of Italy, independently of the regions. Has a tariff, as an investment. So it's really changing. And again, we have a quite consistent and important hospital database, but what we would like to build is a database that includes not only hospital data, but the whole data of even the family story data. So I think this is exactly what Martin says. The future is now. It's only unevenly distributed.
So the future is now much clearer than it was 2 years ago.
Absolutely. And what I can tell you is that, Italy is leading the G20. We hosted the G20 Minister of Health in Rome early September. This is happening in all the G20 countries. It's not, at least at the discussion. First of all, there were ministers that spent 2 days in person there discussing all of these, because the pandemic has made very clear that the status quo is unsustainable, that of course you have to change at national level, but moreover you have to work more integrated in an integrated and global way. And this is very clear, and if it's clear to politicians now, we can be, I think, hopeful that this is going to happen.
And you think a comprehensive electronic health record system for Italy is still, sort of 5 or 6 years off full implementation?
I hope so, but I am very confident that the push that the European Commission is doing in building a European health space data is speeding up the process in all member states.
In all member states?
In all member states. I mean, there are countries such as Estonia where they already have it.
They have it already.
They have it already. I mean, so it's not a problem of technology. It's a problem of political willingness to understand that is a win-win-win situation. But of course, we have to solve not technical problem, but political and privacy problem.
I mean, the GDPR issue, which the Germans are so keen on. I mean, it's...
Yeah, but sometimes it's used by bureaucrats, the alibi of GDPR to stop the process. One of the main barriers is the reluctance and the resistance by bureaucrats to go in these directions. But I understand that many ministers and many politicians are changing the leaders in these sectors in the ministries, because they don't want old bureaucrats resisting to change, but they want young professionals speeding up the change.
So a new generation are coming in to run this. Is that the same for you, Martin? You're seeing a new generation coming in?
Yeah, definitely. I mean, politicians are always driven by their voters, aren't they? In a way, but the voters are changing, and I think the population is changing. I can give you one example from Austria as well. When it comes to data and innovation, about 10 years ago, or maybe even 5 years ago, sharing data with innovators and improve healthcare systems would have been unthinkable 5 years ago in Austria, and it's still very difficult in Germany from what we observed there. Now it's totally turning. It's the patient advocates that want the data to be utilized to improve healthcare. and data are indeed saving lives if you use them in the right way. And I think that's a total change from what we see in the population. There's fewer and fewer advocates who are come up with irrational scenarios that insurance only want data basically to select people for different type of premiums that they issue. I think that's kind of always the major concern. But I think this is, as we all know, irrational because there's legislation that protects these people anyway, so it wouldn't make any sense. But these voices becoming more and more silent, and the discussion is a lot more rational than they used to be. And I think that drives also politicians, and that drives the initiative of a mutual data framework in Europe and in individual EU member states, which I think is a good thing and fuels innovation.
So that's really changed. Good, thank you very much. And Marcus, I mean, how are you seeing this in medtech? Are you seeing a change in approach and?
Not really. I think there is a lot of, as I said before, a lot of recognition. I think the approaches or the change in approach is still a bit too reluctant for me. I would like to see a bit more of an embrace of the potential that certainly innovation and medtech can bring, and so I think we need more active policies here, and I think we need more active financing mechanisms, and that's something that I'm really keen, in the remainder of our time here, to get my panelists' view on, because I would venture, the statement that I see a more active role actually of the healthcare payer in all of this. I feel that in many of our countries, the payer is really, keeping an arm's length, and as long as the healthcare system is funded, that's okay. But kind of more active steering of where funding should go, I think we are leaving this a little bit underutilized. And I want to give you an example. From our space, the development or the innovation, for instance, in our implantable cardiac devices. So a pacemaker, defibrillator, it's a technology which is really characterized by kind of an incremental stream of innovation. So every probably 2 years, there is a new product generation that comes out, and where we constantly improve basically, several features of those devices. One example of an improvement could be longer battery life. So we could and we probably will engineer a device where, for argument's sake, the battery life goes up from 4 years to 5 years. And I'm making this up. Now, the ones we are selling this to is the hospital procurer. So they are the ones who are supposed to unite, if you wish, all value perceptions into a purchasing decision. But I think in most of the countries that we would think of, a hospital purchaser would not necessarily be interested because they're not incentivized, to pay for longevity of a device. But it's clearly a societal benefit. And I think from a payer perspective, a payer would definitely have an interest in that, I would assume, because it contributes to the efficiency gains in healthcare. So at that point in time, I think the payer almost needs to intervene in a corrective way and say, well, hang on a second, we do realize that the way the healthcare system is funded now, or the hospital is incentivized now, they will not pay for that innovation, but that innovation clearly has an economic benefit for the system, as such. So we would need to actually come in there. I mean, to say, we want you to procure that because in the bigger scheme of things, from a payer perspective, that's good innovation, which we want. Okay. And I think if that corrective measure isn't there, it won't happen.
I hear your point. So let's go, Professor. What do you think? I mean, here's a medtech company saying, this device may cost slightly more, perhaps, but it is going to increase somebody's lifespan, which is going to have a societal benefit. And the procurement guy is saying, I'm only prepared to buy on the basis of price. I mean, that's a very well-known dichotomy, isn't it? I mean, how do you feel about that position?
No, I take this point, and I think we have to change the vision and the government and the governance of the system. So if you look just at the health as a cost or as a procurement attitude, you are making a mistake. And so the whole of government, the whole of society, the whole of spectrum of you should be in the basis of the evaluation. And this is not easy because it needs a lot of leadership. And I don't think that there is a lot of leaders that would spend and engage in this change in the future. But we have to go in that direction, because otherwise you just look at the situation from your point of view and you don't look at it. So I understand this. And I think, again, that the next generation EU with the resilience plan that all member states are doing is going in this direction.
Right. I mean, we've seen the huge societal impact of COVID on society, and therefore, in a sense, yes.
COVID has changed everything, and it's very difficult at the moment to understand. First, the pandemic is not over.
Yes.
It will going to last, and it's going to be one of the longest pandemic in the history of the mankind, because essentially, rather than as in the past, where the whole world was convinced to work together to end the pandemic, we have large, not neglectable part of the society, in some cases even politicians who are not going in that direction. So just give it the United States. I mean, in 2 years, they had in the Spanish flu pandemic 670,000 deaths. And this is the case that they're having now. So it's a total disaster and is really harming, of course, not only the health of the society, but the economy of the society. But still now, there is a big discussion that gives two kind of trenches, one the scientists and one the politicians. They have to work together looking at the situation as a whole. If they are divided, I mean, the pandemic will last for decades.
Yes, that's a cheering thought.
No, that's the evidence. You know, in Italy, I'm called Professor Lockdown, you know, because I'm one behind the lockdown of the whole countries. I remember the meeting with the ministers of health of the neighboring countries. I mean, they couldn't believe that we locked down the country. That's what has happened. Of course, we cannot allow now to lock down an entire country, but there are a lot of strategy that can really put together health and economy. The problem is that some countries are not doing that. And this is just a short seeing.
Yes, yes. Thank you. And Martin, what about you? Do you? I mean, I suppose at one level, the argument that medtech puts forward on you know, the improved societal benefits, you can see that, but then again, there is a price argument, isn't there? I mean, what's your view on how to handle that?
Well, as I said already, I think that the biggest we are in the midst of the second industrial revolution, and what fuels that is, in my strong view, is big data and how we use big data. We haven't really used it yet as much as we could and we should do, but I think the amount of knowledge that we gain from it and the discovery will give so much opportunities to medtech developers and also to pharmaceuticals, the drug developers. We will basically find answers of questions we have never asked from the big data approach, and the amount of technology opportunities that I see from that is almost limitless. That's the big hope that I have. And then the other thing that we get with the big data approach is it's not just ideas that are showing a plausibility. With big data approach, we can create evidence in a much better way as we were able to use it in the past. And I think that those two kind of elements that come out of big data makes it affordable, perhaps the innovation that comes up, and it makes it come closer to create real value for the patients.
Yes, much more clarity. Okay, well, thank you very much, panel. We've come to the end of the session, so I'd like to thank you very much for an interesting, great panel. Thank you.
Thank you.